When you have intercourse, is there any pain? Some will say yes, and especially when there's deep penetration. That is actually one of the other signs. They say, Daktari, when my husband or my partner wants to have sex, sex for me is torture. Yeah. When you take the history, it will give us, almost 90% chances sure that this is endometriosis.
It's been such a long break. I feel like this is a reunion of some sort. My guests again, Caro, your health coach, Dr. Kireki Omanwa. When I go through the feedback that we have been receiving from those who have been following keenly these conversations, you feel that it has come to, it's an in-between. There's a gap that apparently was so big, but it's narrowing over time because of such conversations that we have been having here. And I just want to thank you so much, the two of you, for the contribution that you have made in making sure that our people are informed and that finally we begin to have these conversations that are life-changing as far as our reproductive health is concerned. Thank you so much once again. Welcome to the Reproductive Health Series.
Asante. Asante sana.
Today we want to talk about something that has been on the lips of many in the recent past, and this is endometriosis. Of course, if you're in Kenya, you're familiar with one of the heroes that has been on the forefront in creating awareness around the issues of endometriosis, and this is the lady that we lost not so long ago, Jambi. And so we just, in her honor, want to really go a little further into looking at it in detail. What exactly is it? And we have a special segment coming up where we'll just be addressing your questions. So keep them coming. We'll definitely make sure that we address them. And so let me not waste any more time and bring in my co-panelists because they are no longer guests. Yes. Let me bring in Caro, let me bring in Dr. Kireki. If you're joining us for the first time and you're seeing these faces for the first time, let me allow them to introduce themselves for your sake. But of course, these are people who now we're all familiar with. Let me start with you, Caro.
It indeed has been a while, so let me first clear my voice. My name is Caro, your health coach, and I am a naturopathic health coach. I help you and I to learn how we can use natural resources to prevent and manage diseases. I complement what Daktari does, and so I passionately do what I do, and I love being here. I'd really missed this platform.
Karibu tena sana.
Asante.
Good. Daktari.
Yes. Thank you very much. Again, we are back.
Yes, we are back.
And my name is Dr. Kireki Omanwa. I'm a consultant obstetrician and gynaecologist. I teach at the University of Nairobi, Department of Obstetrics and Gynaecology. I'm also a fertility specialist. I help couples who have challenges in getting babies. And then apart from that, I'm also the president of the Kenyan Obstetrical and Gynaecological Society. And this space is fantastic because it gives us a forum where we can pass information, and our listeners and our viewers can also get back to us and give us feedback in terms of questions. And some of these questions have been, people have been keeping to themselves because they feel they didn't have a place where they can feel safe. And sometimes their social status did not allow them to sort of interact with these topics that we are talking about. So I think this is a fantastic opportunity for all of us.
Wow. Good.
I think it's also a safe space. I'm admiring how men are feeling comfortable in this space, and even women. But I think men caught up faster, very fast.
For the first time.
For the first time, we're like, wow.
It came as a surprise, really.
As a surprise, and
because even when we were starting, we were really, 50-50. Even when we were addressing topics that were specifically meant for the male audience, we were not too sure if they were going to actually, on board.
Yes. And it's beautiful to see a difference in all these things. But I also think God has really balanced this. When I am seated in the middle of two men, I feel like, yay. Anyway,
you are protected.
Yes, I'm very well protected. So karibu sana.
Daktari said that some of these conversations is because of how our society has been, meant to believe that some of these conversations ought not to take place openly.
Yes.
And that has prevented a lot of people from coming out even when they need help around some of these things. But gladly, that is changing. One of the things that I believe, for instance, a lot of us began to warm up to in terms of learning what exactly it is the issue of endometriosis. Unfortunately, some of us were coming on board quite late, especially when someone like I mentioned, Jambi Koikai, when she came out publicly to talk about her struggle.
Yes.
That's when most people, especially here in Kenya, were, trying to understand, what exactly is that?
Yes.
Is it that serious? And unfortunately, she lost her life battling. And that has really pretty much created a wave of interest. People just trying to really then now understand what exactly is this thing. And
Yes, there are so many questions around it.
Yeah.
So many myths, so many, I don't know, so a lot of fear around it. And I think that is why it is very timely to do that now, so that we can be as a voice of reason. Yes, we can be a voice of reason.
before we even go into understanding what exactly that is, maybe let me start with you, Carol. The fact that, and I'm using Jambi's story as an anchor for our conversation. And she's not the only one. A lot of people have lost lives, in relation to their struggle with endometriosis. But at least when she did, it was a conversation on the lips of many nationwide. What was going through your mind when you heard of that news of her demise in the struggle with endometriosis?
One, I lost a personal friend. She is someone I had worked with. When I remember we did like 2 shows at Trace FM together, trying to create awareness on endometriosis and sexual and reproductive health related issues. And it came as a shocker. For me, it came as a shocker. I was like, wow, okay. But if there's someone who I've seen walk the talk, she's in so much pain because we will learn from Daktari that endometriosis can be very, very, very painful. But in the middle of her pain, she decided, I'll be the voice. And she was so vocal, you could not have ignored her. And I think even her last post before she died, the last post, she was pleading to the president that we can take the treatment for endometriosis a bit more serious. And she has helped women realize, there's a show we did on, let's not normalize period pains.
Period pain, yeah.
Most people, as we will learn about endometriosis, there are those girls who will have those painful periods. They'll wait and wait and wait and wait when they're in their 20s, late 20s and early 30s is when now they are going to Daktari and then they realize, it has really developed. So by Jambi talking about it and so many others, I see Endometriosis Kenya, Kina Elsie Wandera, those ones, I see ladies who are out there talking about it.
Yeah.
However, I feel like there's so much more that needs to be done, and we need to, that's why we need Daktari here to just break it down in a layman's language so that we can be fully able to understand. I've also worked with an amazing young girl called Njeri, who was Njeri and another lady, and we walked through the journey. Of course, it takes years, but because it was earlier in the stages of endometriosis, changing the lifestyle and being very persistent for several years, it cleared. So I've seen both sides. I've seen both sides of endometriosis, and I wish, and I know that Daktari will help us understand it's not just the uterus that can be affected, because I recently got someone who was really stressed because she was like, I already had a hysterectomy. Why does my colon has endometriosis and such things? So this is a conversation we'll keep talking and talking. I remember when we were starting this show, I said, is there a way of summarizing endometriosis? And I think there is no way of summarizing it. It needs to be dealt with from there.
And we don't have to summarize.
Yes.
We can have this
So
conversation
we'll go
for
all
as
the
long
way.
as...
Yes, I'm looking forward, and I'm here to also ask questions on behalf of the women. And I actually think I know 2 or 3 women who are your clients who are walking through the journey of endometriosis through you, and they still come to me now for the nutrition and the lifestyle. Yeah.
Dr. Kireki, what exactly are we dealing with when we are talking of endometriosis? Break it down in a way that even men will understand, especially men.
Yeah, true.
In the shortest time possible.
I don't know whether we can do it in the shortest time possible. But let's see what we can do. You see, before we talk about endometriosis, we need to take a step a little bit back and understand the cycle of women, the menstrual cycle. Women start having their periods around 13, 14, 15 years. That is when the body gets to a stage, the hormones start, working. And now, in most societies, that is a time whereby, you see, if a girl has started having periods, it's a time for her to get married. Unfortunately, there are some societies like that. But that is a time which signifies that actually this young lady can actually get pregnant. And how does that happen? It happens because of the communication between the brain and the reproductive system. And in the brain, there's a particular part in the brain called the pituitary gland. The pituitary gland is also controlled by something else called the hypothalamus. So, as David says in the book of Psalms, that we are wonderfully and beautifully made, it is actually that. We are wonderfully and beautifully made. That as we are growing, from when we are growing, when we are babies, we can become toddlers, we start walking, we become, teenagers. By the time we get to teenagers, there are systems in the body which now become activated, and we are starting now to become grown-ups. We're becoming adults, as it were. And this is what we call the endocrine system, the hormones. There are different types of hormones. There are hormones which control the way we behave. There are hormones which control, for example, in women, we have estrogen. Estrogen is what makes women women. They have a thinner voice, they have big breasts, they have wider hips, etc., etc. They are more sensitive, they are more emotional. It's all because of estrogen. On the male side of things, we have testosterone. We are more aggressive. We have, like Justus has a beard. As you said the other time, that women...
It has a purpose.
Has a purpose.
Yeah. In fact, I'm not shaving
You
now.
have confirmed.
we have a deeper voice, we have more muscle, and so on and so forth. So, in the female cycle, the menstrual cycle, we normally start with the first day of the period. What happens? There is a message which is sent to the ovaries. And the message is basically in terms of hormones. A hormone called follicle-stimulating hormone. Just like the name suggests, when a baby girl is born, she is born with follicles or eggs which are dormant. They have to be activated. In order for them to be activated, that hormone which is sent by the pituitary gland, that FSH, follicle-stimulating hormone, it tells the ovaries, guys, wake up. We need to produce an egg. So very many, hundreds or even about 1,000 eggs are stimulated. But as the Bible says, many are called, but few are chosen. So many of them are called to wake up, but on them there are things we call receptors. A receptor is where that hormone will go and hook on in order for it to waken up these follicles. So some of them will have very few receptors, others will have more, and a few will have very many receptors. So the ones which have very many receptors are the ones which will start growing. So out of those several hundred, you'll find maybe 3 of them are the ones which have more receptors than the others. And even out of those 3 or 4, it is only one which will now grow. And as it is growing, it will release another hormone again, the estrogen that we are talking about. Estrogen has 2-3 other different components, but let's just call it estrogen, the whole of it. Now, that estrogen, as it grows, remember, in the reproductive organ, we have the womb, which is the uterus. We have the ovaries, which are on the side, and we have the tubes, which are on top. And all these have a purpose. So as the follicle is growing, what you call the dominant follicle, it carries an egg in it. And as it is growing, it is releasing that estrogen, which now will work on what you call the lining of the womb, which is called the endometrium. All right? Now, when the follicle gets to around 18-20 millimeters, it will send a message back to the pituitary gland. And it will tell the pituitary gland, don't send any more follicle-stimulating hormone, the FSH that you started. I mean, I've had enough. Like teenagers, they say, Dad, I don't need you anymore. I'm a grown-up now, that sort of thing. So the pituitary gland will say, thank you, I've had your information. You don't need any more follicle-stimulating hormone. But what you're carrying needs to be released. The egg needs to come out. So I will send something else which will help that follicle to do what? To release the egg. And it sends another hormone called LH, luteinizing hormone. So the luteinizing hormone also has receptors on that dominant follicle, which will hook onto it, and then it will cause a little bit of pressure in it. And that pressure will cause the follicle to pop and release an egg.
Wow.
Sawa sawa. Wow. Now, when it releases that egg, that is the time. Normally, if a woman has a normal cycle, 28 days, 30 days, that popping of the egg or the release of the egg occurs usually around day 9, day 10, day 11 of the cycle. And that is called ovulation. Okay. And that is when a woman really feels like she wants to have intercourse. And if she has intercourse and everything is okay, chances of getting pregnant are very high. Now, that egg which has been released will actually be collected by a fallopian tube. At the end of the tubes there, they have what you call finger-like projections. And they will pick that egg, and motions of the tube will actually push the egg into the tube. Now, if a lady has intercourse, and everything is okay, number of sperms is fine, etc. They will now swim through the cervical canal, swim through the uterus, and they actually know where they are going. They will be actually directed. This time, ovulation has occurred on the left side, so you guys go to the left side, not to the right side. So they will swim, go through, there's like a small tunnel, a small hole, which connects the womb and the tube. They will pass through there, the millions of them, and they will go and surround that egg which has been released. And it is at a particular point in the tube. It's not just arbitrary. A particular point in the tube called the ampulla. So that is where the egg is, and they'll have to meet there at a particular time. So they swim, millions of them swim around it, and only one of them will release a bit of acid, and that acid will drill like a small hole in the, let's say, in the covering of the egg. And once it has released that, drilled that hole, as you remember, there's a time we talked about removing. It removes.
From that day, you changed my life.
And then the genetic material goes inside the egg, and fertilization occurs. Sawa. So the egg now, what the fertilized egg starts dividing. First of all, divides into 2 cells, then into 4 cells, then into 8 cells. As it is doing that, you remember the movements that we talked about. The tube keeps on doing those movements, what we call peristaltic movements, and it will be pushing the embryo now into the through the tube and into the womb. And it takes about 5 days.
And the womb was swelling.
Now, the womb, that lining, you remember that lining we call the endometrium? It was being prepared by that hormone which was released at the beginning. Sawa. So, if
Now I understand why you said you are struggling to
summarize,
summarize it.
But
It's
so
a very
beautiful.
complex process, yet
Yes,
also
so
presented in a very
beautiful.
simple and
Yes.
clear way.
So on day 5, that embryo now, what we call a blastocyst, it carries all the genetic information that we need. That you will have, this baby is going to be this tall. He will have fingers which are mommy's fingers. The eyes will look like daddy.
It's determined at that
it
early
is
stage.
determined at that intersection.
So beautiful.
Now, it comes, and then it also will come into that endometrium now, which is now thick, which is ready. It has collected a lot of sugar and other stuff, and it is very well, it has a lot of vessels, and it will also drill a small hole, also an acid, drill a small hole, and hook onto it where there are vessels, and now that embryo starts getting nutrition, starts getting oxygen from those vessels which were prepared, you remember, during the cycle.
Yes.
And now a pregnancy takes place. Okay. What happens when there is no pregnancy? Let's say the period started and all these things happened. The egg was released, but there was no sperm ready to fertilize the egg. What happens is that lining comes out as a period. So that is how periods come about. Okay. The period comes. Now remember, maybe a little bit back, you remember that thing that carried the egg, the follicle. The follicle. Once it has released the egg, it collapses into a structure, which starts releasing another hormone called progesterone. And progesterone, if there is a pregnancy, is the one which is going to support the pregnancy.
Oh, yes.
Okay. Sometimes,
so if there is no fertilization, does the follicle burst? Yes.
Yes. If there is no, the follicle will burst. It will release the egg. Yes. The egg will be collected into the tube. Yes. But if there is no sperm to fertilize it, the egg will be gotten rid of by the immune system. Okay. But then the lining will wait. There's nothing is coming. Okay. Whatever. It will come out as a period.
And so the egg comes out with a period?
The egg will be sorted out. The egg is not in the womb. The egg is in the tube.
Okay.
So what comes out is the period, the lining. The lining which was prepared for pregnancy.
Okay, let me ask like a layman.
Where
does the egg go?
The egg goes, if it gets into the womb, there's something we call the immune system. So the immune system, we realize there is something here which has not been made use of. So what do we do? Get rid of it.
I'm spelling because it's a story told.
Yes.
You can correct.
Go ahead.
But when the egg does not come out,
yes,
it is a form of protein that will make you fat.
No. That is another myth now. That is one of.
I've asked the question on your behalf.
That is one of those myths. Okay. Now, when we talk about endometriosis, first of all, we know that lining is called the endometrium. Okay, so endometriosis is when you have active bits of this lining which are outside the womb, and they can be anywhere. They can be in the muscle of the uterus itself. That one is called something slightly different. It's called adenomyosis.
By active, what do you mean?
By active. What I mean by active is, you remember the whole cycle, the way it started. Yes. That endometrium has receptors. You remember the estrogen that was being released. All right. So this estrogen goes and works on those receptors in order for it to be what? In order for it to grow thick in expectation of a pregnancy. Now, this active bit is that this lining is outside the womb, and it can be anywhere. It can be on the ovary itself. It can be on the tube. These are the most common sites of endometriosis. On the ovary, on the tube. It can be in the womb itself, in the muscle of the womb, what we call adenomyosis. And then it can also be in all other places of the body.
Yeah, like the way it had now gotten to Jambi's pulmonary.
Yes, we'll come to that.
So you're saying that when the process of releasing it happens, that chances are it might not go to where it ought to go in the process of releasing. It can take a different direction.
Thank you. Now we are coming to the possible, what you call, pathology. How does it get there? How does it get to other parts of the body? Nobody actually knows what methods that this lining gets to other parts of the body. We used to think that because, okay, when when a woman has periods, the uterus can contract or does contract, the cramps that women feel, and because of that, there can be reverse pressure, and that a bit of that lining, instead of coming out, can go back into the tube and get onto the ovaries, for example, or stick onto the tube itself, and so on. But if that were to be the case, then it would mean that every woman who has a period should have endometriosis, but that is not the case. Okay. Then there are other theories that maybe we use other system, what we call the lymphatic system, that because the lymphatic system is all over in the body, then maybe it is possible that those bits and pieces, the cells of that endometrium which is active, is actually transported to other parts of the body. We actually are not very clear about that. Apart from the ovaries and apart from the tubes, we can actually find endometriosis in the intestines, the large intestine, around the rectum sometimes. We can find it on the ureter. The ureter is the tube that carries urine from the kidney. We can find it after cesarean section, on the cesarean section scar. We can find it on the cervix. And usually we see this when you're doing a speculum examination. For a pap smear, you just once you put a speculum, you can actually see this is endometriosis.
So what exactly, when you're looking on the lookout for possible deposits of the same in different?
Yes, we'll come to that. You can find it some women who have delivered naturally and they have what we call an episiotomy, a small cut to allow the baby to come out. Sometimes they can actually be found there. Some have been found around the umbilicus, kwenye kitovu. It has been there. And a good friend of mine actually the other day on one of our walls said, he's had a patient who was, I think she was 16 or 17, very, very unusual type of endometriosis, where, first of all, she started with the normal symptoms and so on, and then she started bleeding from the joints during the periods, and then it got to bleeding from the palms, and then she started bleeding from the eyes and from the ears as well. Very, very rare form of endometriosis. I've had a patient who's had, from the symptoms, you see she has endometriosis, just like in Jambi, in the lungs. The other day I had a patient who, from the history, she has endometriosis in the shoulder joint, and in the hip joint as well. Okay? So it's an enigma sort of disease. We actually do not know how these active parts of the endometrium get to all these different. One of our professors said he had a patient who would bleed from the fingers. There's time for whatever she has bleeding from the fingers. Yeah. Now, how do we know that this is endometriosis? I think several years ago, I think maybe 3 years ago, I read an article where they had actually done a study in Europe. And the European health system, most of the European health system structure is very well structured. They have a general practitioner, they have this and that. So everybody has a doctor. And from their study, it came out that in Europe, it takes an average of 11 years to actually, from the time a young lady has symptoms till a definitive diagnosis of endometriosis is made, it takes about 11 years.
With all that?
With all the structures, with all the whatever, it takes about 11 years. So I asked myself, if in Europe it takes about 11 years, what about in our countries? It may take forever, or it may sometimes never be diagnosed at
Why
all.
is that the case?
Number one, I think, is because of the symptoms. Because usually, a colleague of mine some time ago did a small study for his master's degree thesis, and he went to a school and he gave out a questionnaire. And he was interested in endometriosis. And he asked, do you get these symptoms, and when do you get them, and so on. From the study that he did, it was around 200 or 200, about 300 students. 20% of the answers were actually symptoms of endometriosis, and that was in one school. So imagine the hundreds of schools that we have. Imagine the hundreds of thousands of our girls who are in these schools who have these symptoms, but they are either neglected or they are downplayed and whatever, and later on they have serious complications.
Does it play hide and seek? Because I'm also thinking that could also be a reason, like the fact that we've said it can grow anywhere.
Yes.
I suspect, does it play hide and seek? It can.
Where you end up
hiding, then
you end up treating symptoms
really,
that perhaps you associate with
yes,
something totally different.
because maybe
Yes.
that also makes
Yes.
it longer, makes it take us longer for us to be able to see it.
Are
Are there cases where it hides or it moves?
Because of the symptoms, it really can't hide. Because of the symptoms, it can't hide. Because when you listen to a patient, when you take a history, you will know this is 90%.
Yes.
This is endometriosis most of the time.
But now, like this one for the bleeding, for this.
Exactly. That is where the history is important. When was the first period? When was the last period? How are your periods? Are they regular? Yes, they are regular. How are they? Are they heavy? Are they light? Are they this? Oh, they are normal. Are they painful?
Yeah.
Extremely painful. That is one, the first
They
red
go
flag.
through a lot of
Extremely painful. And then now we take a break on those pains. When does this pain start? They say, Daktari, this pain usually starts either a few days, a day, or even up to a week before the period starts. That is another red flag. And then what happens with this period, with this pain? It comes and then it reaches the highest point, the crescendo, just when the period starts. And then after the periods, as the periods progress, the pain starts doing what? Decreasing. And then after 3-4 days, the pain completely disappears. Third red flag.
Yes.
And then what happens? Does it start again? Yes. So the pain is cyclical. Every month it is there. Every month it is there. When did it start? It started usually, actually when I started my first period, around when I started my first period. There you go. So pain, when it started, the cyclical, nature of the pain. Okay, when you have this pain, what happens? Or sometimes I can't even go to work. I can't go to school. I can't attend classes. Are there any other symptoms? Sometimes I vomit, sometimes I have diarrhea, sometimes I have this. The vomiting and the diarrhea may not always be there, but sometimes that could suggest something else. But the cyclicity of it, and that one that it actually affects the quality of life. Cannot do the normal things, because that's what we ask. Does it allow you to do the normal things that you do in life? No. I can't. I'm in bed for 2 days, I can't wake up. Or 3 days. Every month. Ladies have actually got dismissed from work because of that. And their bosses ask, kwani wewe ndio mwanamke wa kwanza? Are you the first woman with periods? All of us have periods. And unfortunately, the worst people are the bosses who are women. Because they say we also have periods, but we don't behave like this. So this
Even
is
parents
something.
who dismiss their
Even
their
parents,
teenagers.
even parents, they
Because
say,
you're using your own experience.
Yes. Or even the mother will say, even me, I used to have periods, painful periods, but I managed. So.
And they make it worse. They say it's not. Is it childbirth? Why are you disturbing us? Childbirth is the most painful. They don't know the intensity of the pain.
But it can actually be worse than childbirth.
Really
it can actually
painful.
be worse than childbirth.
Really painful.
And then the other thing.
And I keep wondering.
Yes.
why, okay, I'm just thinking out
Yes.
loud, maybe, why is it that painful? Is it the wall that is trying to...
Yeah, now that is now
break?
the physiology of it. Now, you see, wherever that that endometriosis is, coming back to that question, active lining, that bit of endometrium, wherever it is, will respond to the changes in the hormones exactly like the womb.
Oh.
You remember we talked about the lining growing thick and then growing. It will respond exactly the same way.
It will think it is in the womb.
It will think that it is in the womb. So when whatever starts the estrogen, it will grow. It will respond.
And hormones are still changing.
And the hormones will still continue.
in and
Every day
out.
they are working. So that is one of the reasons of the pain. Wherever it is, it will expand. And that is why that pain, 1 week before the period, because the lining, normally that lining is supposed to come out, it's preparing to come out, and wherever that other lining is, it will think I'm also preparing
I'm also part
to do
of the
what?
process.
To come out. So maximum.
And then I'll bleed.
Maximum. Then it will bleed as well.
Now
And
I
then once the period has gone, that place where it is, it will also become small. That is number one. Number two, wherever it is, because it is something which is foreign, is not supposed to be there.
Yeah.
You remember we talked about the immune system.
Yes.
The immune system will recognize there is a foreigner
there's
here.
stranger
Endometrium is not supposed to be on the ovary. It's not supposed to be on the tube. What do? Send soldiers there.
Fight.
So the soldiers will send there. They will try and limit its growth. Okay, and then by doing that, it will now cause scar tissue. It will cause the tissues to sort of, be pulled together, and whatever, the nerves will get involved, and so on. So now with that, remember, they have tried to, the immune system has tried to limit that endometriosis to that place. Now comes the hormones during the cycle, and they start working the same way. So we need to grow, and then it grows. And by it growing, it's pulling all these other tissues, the nerves which are involved and everything. So that's where the pain comes from.
Is fighting,
and the immune system is
Yeah.
fighting as well.
There's a lot going on.
So there's a lot going on. Now imagine you have several of those sites.
in different
You have in
places,
different places.
yeah.
It reaches a place whereby the whole reproductive system, the ovaries are involved, the tubes are involved. When you look inside the pelvis, you find the rectum, where the rectum is, and where the uterus is. They're actually very close together. And if the rectum is involved, it will get stuck to the uterus. So you find it reaches a place where everything is stuck. And remember, the hormones are still working every month. Estrogen is being released, the lining is still growing. So wherever those bits and pieces are, they are going to continue doing exactly the same thing. And so the whole process, pulling, tugging, pushing, lining, I mean the nerves are also involved and so on. So the pain comes from there, and it's excruciating
Do
pain.
men get endometriosis? It sounds very unfair. But unfortunately, they don't have
We don't have a womb.
Oh my goodness.
And we don't produce estrogen as much. We produce estrogen, but very small
lucky.
amount. Very, very small amount. So men do not have endometriosis. Cannot have endometriosis.
So apart from the pain,
Yes.
what's the worst case scenario in terms of the damage? Because now when we are talking about someone losing their life,
Yes.
how does it escalate to that level?
Now, remember, this is the immune system is involved, and now all these other structures are involved, and the pain. The other thing that we ask is when you go to the loo, when you're having, when you're passing urine, is there any pain? Sometimes they will say yes. That will mean that the bladder is involved. What about when you go for a long call? Yes, we have pain. And sometimes there is blood on the stool. When you have intercourse, is there any pain? Some will say yes. And especially when there's deep penetration. that is actually one of the other signs.
Signs, yeah.
They say, Daktari, when my husband or my partner wants to have sex, sex for me is torture.
Yeah,
It's torture. That is also another sign. Okay? Now, when we put all these things together, we need to help these patients. You ask, how does it get to that place whereby, a patient loses her life? There are different ways of managing endometriosis. And of course, it depends on the extent, the intensity of it. They can be very mild, in that the symptoms are there, but they are not debilitating. We ask on a pain score of 0 to 10. Let's say 0, there is no pain at all. You are, everything is fine. You have periods, no pain at all. And 10, it's such intensive pain, such that you cannot be able to do anything. Sometimes you can't even be able to wake up from bed, and so on. Some of them say we have 15 out of 10, meaning it is something which is maybe worse than even childbirth. You say at that time we can't do anything. I can't sit. I can't lie down. I can't stand. I can't walk, and so on. So once we get this history, because as I said, when you take the history, it will give us almost 90% chances sure that this is endometriosis. Do you take painkillers during the Yes, we take painkillers. But sometimes even those tablets don't help us. I have to go to hospital and they have to give me a drip. And I think that is what that lady had suffered for so many years.
Yes.
That when the pain comes, she has to go to, otherwise she cannot function. And then now progressively, you'll take the normal painkillers, paracetamol, whatever it is, which generally should be able to manage this pain. But then it reaches a place whereby they are not working. So we progress to more, heavy duty, let me call them heavy duty painkillers, what you call opioids. You can start with pethidine, for example, and then we go to morphine. Sometimes it gets to a place even with morphine, does not work. And morphine is the real heavy duty. Now, I had a patient who actually got, because of the pain, because of trying to manage it, unfortunately, the other consequences of using opioids for a long period of time is to get addicted to them. So 100 milligrams of pethidine knocks you out. Normally, you've never used pethidine, but it knocks you out. But this lady would take 200-300 milligrams, and she would still feel the pain. Unfortunately, very, 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 very sad. Yeah.
I'm also thinking. Okay, you asked, but I wanted to add on to what you asked.
Yeah.
At what point does it get us to even almost death? Remember, there's bleeding. So anemia is also something else.
Yes.
Remember, the immune system is trying to fight to help you. The immune system is really trying, and at some point, if care is not taken, it might end up being an autoimmune, the immune fighting an autoimmune disease. So when all these complications are not handled carefully, they can result to that. And I think I need to ask, is it possible that it can start from my uterus, then it keeps growing, and later it can move to my colon, it can move to this, and end up eating me up slowly to other different parts. So at that point, you are eaten up. Because from what Jambi shared was like, it's like it had really eaten her slowly and slowly and slowly, had gone up and gone up and got to a point now it had nothing else to eat.
Yes, it can do that way. It can start slowly. As I said, sometimes it's very mild. You give medications and she's sorted, and she's fine. But it can grow slowly by slowly, especially if it is not diagnosed early and appropriate treatment is not applied. You find it has eaten, as you said, it has eaten the ovaries, it has eaten the tubes, it has eaten now the rectum, and then it starts spreading, it starts eating the bladder, it eats the ureters, and so on. So, as you said, when it affects all these organs, that is when it becomes very, very complicated to treat, because we have what we call a frozen pelvis. A frozen pelvis is where all these organs, which are the reproductive organs, normally they're supposed to be free. Remember, we talked about getting pregnant, there's that movement and so on. You find that tube cannot move because it is stuck.
Frozen. Yes.
The ovary cannot work the way it is supposed to work. They're what we call endometriomas, a cyst, which contains all that blood, and it's called old blood, as it were. And those cysts can be humongous. They can be a few centimeters. They can be 10 centimeters, whatever. And there can be several of them at the same time. And some of them can have that blood, as it were. And some of them can contain also clear fluid as well, and so on. Now, because of that distortion in the pelvis, they will pull all the structures together. So you find normally the ovary is supposed to be on the side of the uterus. You find it has got stuck to the uterus. The tube has got stuck to the uterus. There's a sign we call kissing ovaries, where the ovaries are supposed to be completely separate, but they're stuck together. And then on top of that, you find the rectum has also stuck there. The other parts of the large intestine, whereas they're supposed to be freely moving around, you find they're stuck on the bladder, for example, and so on. And then it spreads. It goes to the ureter, the part the tube that actually brings urine from the kidney into the bladder. It is there. So now the consequences are now horrible, because if it has attacked the ureter, or ureters for that matter, urine will not be flowing normally into the bladder. So there'll be urine retention, what you call hydronephrosis. If there is urine retention, the kidney is a factory that sieves the blood, cleans the blood of its impurities, as it were. So if it is not working the way it should, because the urine is retaining there, it's going to affect the whole body. If the rectum has been affected, the rectum, you're not passing stool the way you're supposed to. There's a joke where the eyes said they're the most important. The brain said, I'm the most important. I mean, without me, the body can't work. The lungs said, no, it's me. I mean, without oxygen, there is no way you're going. And then the inner said, I'm the most important. I said, no, look where you are. What kind of? He said, okay, let us see what will happen. Yes. And it blocked.
And everyone was screaming.
So when that part actually gets affected and stool is not coming out, the repercussions now touch all these other parts of the body. So apart from the bloating, your kidneys are not functioning well.
Prone to more infections.
You have to go for dialysis. Your liver will not be functioning well, and so on and so forth. So the consequences are really horrible.
I see several times when maybe the endometriosis is not too progressive. I believe it is also staged.
Stages, yes, it is staged.
Stages.
Yeah, it is.
You take some women to the theater, and you are able to. I'm about to use the to cut it out. To cut it out. But is that something?
And even before you come to that, because I believe that now perhaps part of when we're talking about remedies and way of managing. Most of the things that you, in terms of the signs, the symptoms, the pain that you've described, makes me wonder what's the correlation or difference when you're talking about endometriosis and something like lupus.
Lupus, yes. Lupus is slightly different. Lupus, of course, the pain may be there, but the pain is not cyclical. It's not cyclical. It's not there every month. And then lupus will affect other organs first. For example, it will affect the kidneys. It will affect because it's an autoimmune disease, basically. That one is slightly different. So the periods will be normal. They are not cyclical. The pain is there, but it's not cyclical. Pain during intercourse may not be there, but in endometriosis, it is one, especially when it is deep infiltrating endometriosis, these signs are there.
Okay. Now you can respond to Carol's, but also tie it with maybe I don't know if it's a myth or it's the issue of now, because all this wall is coming out as a result of lack of fertilization to begin with.
Yes.
You know, so when you have fertilization in the process, does it make anything? Does it make things any better?
Actually, it makes everything a whole better.
Oh,
I had a patient who had endometriosis. Actually, she was a good friend of mine, and she came, and they'd been trying to get pregnant for I don't know how many years, and it hadn't worked. He had miscarried, I think, 2 or 3 times, and they decided to adopt, and they adopted a young man, and everything was fine. And I think the pressure now of having a baby was sort of removed from them. And she came to me and he said, "I'm feeling some funny, discomfort, low abdominal pain and whatever." So I did a transvaginal scan. I had I don't want to call it beautiful, but it was a beautiful endometrioma.
It sounds wrong calling it.
It sounds wrong. It sounds,
beauty is in the eyes of the beholder.
It is so easy to diagnose. I said, "Oh, it's endometriosis." I think 9-10 centimeters. So a big cyst. Now, normally with such a cyst, chances of getting pregnant are very, very low. And I told her, "Look, this is what it is. We need to do surgery. We remove it, and then blah blah blah." She was very, very, very cautious, reluctant to go for surgery. I said, "Fine, you go and think about it, and then once you're ready, come, let us talk." She came back after 2 months or so. It was a very good friend of my wife. So she called my wife one day and said, "I'm feeling a bit funny. I'm feeling a bit of nausea, but I'm not very sure what is happening." My wife said, "I think you're pregnant." He said, "No, I can't be pregnant." He said, "Are you sure?" He said, "I'm very sure." He said, "Okay, let's wait and see. Have you done a pregnancy test?" He said, "Not yet." He said, "Okay, go and do a pregnancy. Just to do a pregnancy. Just to do. You know how you ladies talk. Yeah, just to do." So she went home and sent her husband to go and get a pregnancy test. So, as he's looking down. So anyway, this guy goes to the chemist. That was in Poland where I was working. So he goes to the pharmacy and asks for a pregnancy test. And everybody's looking at him.
Are you sure?
I can imagine.
So she does this test, and the test is positive. She's pregnant with a 10-centimeter endometrioma. Normally doesn't work that way. Anyway, she carried the pregnancy to term. But what happened is that with the pregnancy progressing, that endometrioma reduced in size until it became tiny, insignificant. What we are saying is that, yes, you remember we started with the implantation and pregnancy and all that. Now, when a woman who has endometriosis gets pregnant, actually the ovaries don't work for the next 9-10 months, and so it actually stops the endometriosis.
Because now there's
the cycling.
It is not there.
Yeah.
It is not there.
Does it feed the baby?
No, it doesn't. That's a different story altogether. It will starve because the ovaries are not working.
Yes.
They are not producing estrogen. Yes. So wherever those bits and pieces are, they'll be starved of so they won't grow. They'll actually disappear
and
most of the time.
Then in that case, it means that even the client that I recently got who says, "Yes, I did a hysterectomy, but I still have endometriosis," because they left the ovaries.
They left the ovaries.
So the cycle is still...
So if the cycle is not there because the uterus is not there, but if there are any spots wherever the endometriosis was, and there is estrogen being released anyway, it may still feed those spots where the endometriosis was. Yeah. So that is why sometimes you find some of our ladies complain, said, "I went to a doctor and he told me, get pregnant." That sort of thing.
That's how they say it.
It's how they say it.
I accept your apology. Or it's how they say it. And women are like, but pregnancy, I can't go to a shelf and just get a pregnancy.
Just get a pregnancy.
I don't even have a partner.
Exactly.
It's how it's said. But now when you explain it that way, I will
Yes.
understand and I'll go and work very hard. And get pregnant.
Work very hard.
In there, you have to work hard.
8 to 5.
To make sure that I get better. But now it all makes sense. And I also thank you so much for explaining that, because now our audience needs to know why it is important that when you go to daktari, your lifestyle has to be in line with what you're doing.
Yeah.
Because what my takeaway point is, all this is dependent on the release of the hormones.
Yes, and your awareness of that cycle.
The whole
It
process.
is so important, because basically the whole of gynecology is about that cycle. Everything we do is about that cycle.
Yes. So then it means most of our foods in the stores today, they have a lot of preservatives and additives. Guess what makes the preservatives and additives? Synthetic estrogen.
Very, very possible. There have been studies which have shown that even in water, there have been residues of hormones, which are also affecting men. But that's a different story altogether.
You open him up, it's like, what? So herbicides and pesticides still have synthetic estrogen. So even if we are doing whatever we can with daktari, and your diet is rich in processed foods, you are doing the you are giving more chances to the endometriosis to grow. If you don't exercise,
you're creating an
when
enabling
you're not
environment.
Yes, so that is why lifestyle is very important. Exercise when you're not in that pain is very important. When you are overweight, these problems. When you're smoking cigarettes, when you're taking alcohol, you're just adding fuel to this fire. So as much as you're going through this whole process, don't expect that daktari will do a miracle without you changing your lifestyle. Also, don't expect me to do a miracle with a lifestyle without you going to daktari. And I think that is the catch of endometriosis, because it's a lot of hard work. To go through it, it is a lot of hard work. To manage it, it's a lot of hard work. I've worked with wonderful girls, and I'm not even ashamed of talking about this girl who we have worked since 2020, 2021. She had adenomyosis, endometriosis, and all these things. And she had her third surgery. She told me, Carol, now I'm tired. Now please teach me. And we started the journey, and I've watched her improve and become a better person. The pain is managed. The pain is not as bad, and she's able to do her exercises, eat a good diet, a healthy diet. Stress levels also really affects, right?
I think the stress levels will come from the pain. The pain.
Yes.
So the pain will make you
and the fact that it cuts you off from your social life.
Yes.
And also the societal. I've watched women who are married.
Yeah.
They have endometriosis. They're in pain. They are not conceiving. The husband is not understanding. The in-laws are not understanding. All that. So you end up just throwing away the marriage.
Yeah.
You throw away the person who is giving you stress, and you go and try and find space for yourself.
That is true.
Yes.
What do we do now?
What do we do? I think there are many things that we can do. First of all, even before we go to what we can do or what we do, the management and the treatment of endometriosis. This will depend on the symptoms and how early has it been caught. If it is very, very early, just the normal analgesics or painkillers will actually be able to sort it out. But there's a whole array of medications that we can use. You can use oral contraceptive pills, for example. So there are societies which say that oral contraceptive pills are not medications, but they are. By using them, basically what we are saying is that we stop the ovaries from working. Remember that communication we talked about, the pituitary gland and the ovaries is cut off, so there is no estrogen which is being released, a lot of it. Whatever is being released is just very little, and so they will, wherever the endometrium is, will not be able to be fed, as it were. So that does help to a certain extent.
I have a question.
Yes.
Why have we, as a society, made the oral contraceptives a solution for any problem even before we get to know what the problem is? Women will tell you, and I know they will write, I would encourage them to write, to see, so that you can hear how many women are being put on oral contraceptives without such an explanation, without first knowing where the problem is. Because maybe some is not even endometriosis.
Yeah, it will be something completely different.
Something totally different. But we are rushing to give the oral contraceptive.
I think it's because, unfortunately, in Kenya, some medications are not very well regulated. And we have these vibandas everywhere called pharmacies, but they are not pharmacies. Anybody can actually open, unfortunately, and that is not right. Number two, we can practically buy anything over the counter, and that is where the problem is.
Yeah, because even the young girls are being... it's a teenager whose body is trying to recover, and you're given the oral contraceptives before we know what exactly
that is why that history is very, very important. Very, very important.
Please take note.
Such that, and in order for that history to be important, you have to see your healthcare provider. You have to see a doctor.
And give all the information and follow through. Before you give this medication, the contraceptives.
I mean, some people call and say, the other day I got a call from Australia saying, Daktari, I'm here with my wife and we are trying to conceive. We have lost, I think, 3 pregnancies. How can you help us?
Thank you.
I said, you're in Australia.
I'm in even Kenya. On phone, I cannot treat
I can't help you over the phone. I can't. There are some tests which I need you to do. There's a history which I need to get from you. He said, but you can just prescribe those tests. We can do them in Australia. I said, test is something else, but I need the story. I need to hear it, and I need to synthesize it so that I can be able to help you. I said, I'm sorry, I can't help you over the phone. It's going to be very difficult. Hop onto a plane and come to Kenya. I'll be able to listen to you, and I'll be able to try and help you. But over the phone, I can't help you. And even when
there's interpersonal relationship, there's so much that comes in.
There is so much information. I think this is also
a chance for us to tell our viewers. I know you write so many messages. I've just shown you how my Instagram looks like. And you want answers on Instagram page, on DM. It's not possible. All the sexual and reproductive, actually not just sexual and reproductive, I think all this needs to go. You come physically and let's have this conversation. Maybe there's a question, the one question. I'll look at you and you're like, okay, that was the problem. So please, shortcut.
Shortcuts are not good. So that treatment, medication, so it can be conservative treatment, can also be surgical management. So in the conservative is the painkillers. We have oral contraceptive pills, for example. We have injections which can be used once every 3 months, once a month or once every 3 months. But the only thing is that with that injection, again, you remember, we go back to that cycle, it stops that communication between the pituitary gland and the ovaries. But then the side effects of those injections is that you may start having night sweats. You may start having palpitations. You may start having, mood swings. So it is actually what we call chemical menopause. We can do something called add-back therapy by giving you something else. But then if we start using these injections at a very early age, you may also have other issues, for example, with osteoporosis. The bone, whatever, starts reducing, and your bones start becoming brittle, and so on. And so there are quite a number of things which you have to take into consideration before we use some of these medications. Now, with the surgery, the best type of surgery that we can do in such cases is called laparoscopic surgery, where we make small incisions on the abdomen, fill the abdomen with gas, carbon dioxide, and then we go in with instruments. We are operating here, but we are looking at a screen what we are doing. And actually, we can do a lot. And there are doctors who have actually sort of gone and specialized in endometriotic surgery, because sometimes it can be very, very complicated. While operating, you may injure the bowels, for example. You may do this. So we need to have what we call a multidisciplinary team. as a gynecologist who's operating, I have a surgeon with me, for example, who, if I were to injure, or if the gut needs to be dissected, because sometimes you need to cut it and remove it, then we have a surgeon who is able to do it laparoscopically. That is another thing. Coming back to what we can do. What we are doing now is one of the best things, because we are actually advocating, we are sending information out there. And there is nothing as important as information. Knowledge is power, as it were. So let the audience and our viewers get this information. If they have any of these symptoms, or if they're in doubt, they should see a doctor as soon as possible. The earlier it is diagnosed, the better.
And easier it is.
And the easier it is. That's number 2. Number 3, I think, as Jambi was saying, the government should take a little bit more concern in these areas. So we need to have more gynecologists actually trained. We need to have even specialist centers. In some countries, I worked in a specialist center in the UK, where they used to send these patients who had serious endometriosis for surgeries. We really don't have such centers per se. And the issue is not just having a center, but it has to be a center where you have multidisciplinaries, where you have the doctors, the surgeons, the gynecologists. We need psychologists as well. We need nutritionists as well, and so on, such that it is dealt with holistically. And come to think of it, endometriosis affects about 10 to 15% of women. It's a huge population. And usually patients come because they're trying to get pregnant and it hasn't worked. So when you take the history is when you find there is a problem here. Most probably it is endometriosis. And then when you do a scan, sometimes it is just like, it's obvious this is endometriosis. It's basically a confirmation. Now, the other issue is about diagnosis, because there are 2 ways of diagnosing. After listening to the medical history, there are 2 ways we can do it. The best thing is to do laparoscopic diagnosis, because laparoscopic diagnosis can be the diagnostic and therapeutic at the same time. You put a scope there, you say, aha, there's endometriosis, let us remove it, for example. But we lack the equipment. And then we also lack the personnel.
When you say
I'm saying Kenya.
Kenya now.
I'm saying Kenya. Because, for example, if you go to Wajir or Mandera or Migori, or even in Nairobi even in Nairobi here, you may find actually we don't have the equipment. And that's number 1. And number 2, the personnel, human resource, which is actually trained in getting this information as quickly as possible, and also diagnosing it by doing that, diagnosing and treating at the same time. Now, there is what we call the Endometriotic Society, the World Endometriotic Society. They suggested that in some countries like ours, what we call low, medium income countries, they acknowledge that equipment is a challenge, human resources is a challenge. They say what we can do, we can actually do a surrogate method of diagnosing endometriosis. And what is that? A patient comes and says, I have all these, these symptoms, and you may not have access to the equipment, or maybe you also may not have the skill to actually be able to treat her. They say, put her on medications for 3 months. So put on medication for 3 months. If the symptoms disappear or improve drastically, then you actually have a diagnosis of endometriosis.
After now you have seen.
After talking and everything, saying, okay, fine, because I don't have all this, I may not have, because by the time I send this patient to KNH or wherever it is, where the equipment is and the personnel is there, may take several years. Give her medications.
Okay.
Particular type of medication, what we call progestins, and let her take continuously for 3 months. If she comes back and says, Daktari, acumenisaidia, the pain has gone. The symptoms, then it's a confirmation. So actually, it's a surrogate way of confirming.
Is there any for a parent who is watching us,
Yes.
who is a mother to a 17, 18, 20, 20-something years old girl
Yes, yes.
who has been having very severe painful periods.
Yes.
Can we diagnose? Can we do the test on those girls to confirm, or we can?
Yes, we can.
Okay.
Yes, we can. Yes, we
Okay.
can.
Okay.
Because the medications, these are not contraceptive
Contraceptives.
pills.
Yes.
It's a different thing altogether.
yes.
Because some parents may say, you're giving my daughter hormones, contraceptive pills and whatever. These are not contraceptive pills.
Okay.
Yeah.
Okay.
And the issue of cost, even as we come to a close,
Yes.
the issue of cost now on the part of the patient, because as much as we're talking about the gaps, medically, equipment, expertise, also for those who would really love to come out and access some of these services, there's always the issue of cost. And I don't know, in your capacity as COGS, president for COGS, is there any conversation around it in terms of even making sure that some of these, because we have insurance, the government insurance, but some of these, diseases, conditions, patients never get to benefit from the insurance. Is there any conversation to making sure that you cushion some of our people to be able to access easily?
You're on the spotlight.
Actually, hot seat.
Justus did that to you.
Can you imagine?
Imagine. I thought we were friends. Journalists. Anyway.
Actually, that is a good question and a very important question, because it's not only about endometriosis, but we also talk about oncology cases, gynecology, oncology cases, not even to mention about infertility, which is a big problem in this one, and so on and so forth. Now, remember that the government is changing from NHIF to SHIF. As well. So we were invited as a society to actually give the procedures that we normally do and actually costing them. And we did cost them, and we sent them to the authorities that requested us to do that. Whether our costings, because these were real costings, whether they'll be taken into consideration, I have no idea. Because remember again, the government is grappling with issues of cash flow, as it were. For example, what I saw from one of the reports, and it was actually published a few days ago or a few weeks ago, was that, for example, even normal delivery is going to cost 10,000 shillings, and a C-section is going to cost, I think, 34,000 shillings. Is that realistic costing? No, it is not. It is not realistic costing. So imagine if a CS was 34,000, endometriosis surgery, which is very complex, and we put our figures there. We don't know how much that is going to be, but we always hope for the best. We have done our bit, and then the government also has to do its bit. We are really trying because sometimes it's an issue of maybe lack of information, and the mandarins in Treasury or in Afya House, they may not have contact with these type of cases that we are talking about. So we are also doing advocacy to try and show them that this is where we are. That is number one. Number two, I think pressure groups would also help a lot. Patient pressure groups, because we have patients who have gone through this process, and the case in point that we started discussing with, it has opened up this space, quite a lot. And so we hope that by doing all these things, we'll be able to make it better for the patients, also create awareness. March is Endometriosis Awareness Month. So we as a society have always strived to do a lot of advocacy, talking in the media, holding meetings, sometimes with patients who've gone through this, and so on. So advocacy never ends. So it has to be continuous. Yeah.
Yes, I'm really admiring Egypt. I've been reading a lot about what they are doing. They have come up with beautiful, what you were talking about. They are trying to put up specialists, equipment, everything around endometriosis. And so far, so good. I admire what they're doing, and hopefully, maybe someday we'll also get there.
As our compatriot says, our dreams are valid.
Yeah.
We can make strides one at a time.
Yes.
And this is part of that journey.
This is part of it.
Yeah, I'm really glad that we can have this conversation in such a manner. And hopefully we're able to follow up. And thank you for the work that you're doing, even as COGS. And we hope that you can also mount enough pressure because you have the capacity to. And all that will benefit our people.
Definitely.
Let me hear your final thoughts on this before we end this show, because clearly there's so much around this subject, and hopefully we can then come back and do follow-up conversations on the same, and even celebrate some of the milestones that we have made.
Absolutely.
Yeah, let me start with you, Carol.
Wow, first of all, I am so enlightened. I admire how Dr. Kireki teaches. You are more of a teacher. And even I'm seeing fallopian tube dancing.
You already see, visualize, you're able to visualize.
Yeah, you help me visualize everything. And I believe our audience, I know our viewers are also learning from this. It is quite an encouragement that we can sit down and have these conversations so calmly. And I think for me, it would be, I'm calling on our viewers to write to us so that you can see the intensity of what is happening out there. Don't write that we cannot treat you on the show, but please just share your experiences so that we can get to know, and also so that we can be able to do something about it. One thing I've learned, and one thing I have been consistent on telling our viewer is, this is not a one-man job. We need to go around it psychologically, physiologically, nutrition-wise, biology, every area of the aspect. And even if you are a man there and your daughter or your sister or your mother or even your wife is going through this, you have a responsibility of helping them through this, because it's not easy. It is not easy at all. So if we can come together, and I think I've got a moment where Daktari has said we need some good viable noisemakers. I'm a good one. I can viably make, because I also believe in advocacy. I believe in policies being put in place. It's a wake-up call. Endometriosis Kenya, it's a wake-up call for you as well, and every other person in that space. Let us just wake up and let's talk about it. Let's also push and see how we can be able to benefit. However, we cannot treat endometriosis by avoiding a healthier and easier and better lifestyle. That is where I come in with R&B, and R&B is Rejuvenating Nature's Beam, and we consult and we listen and we look at the psychological ways of helping, the nutrition, the exercise, all these things, so that Daktari can be able to take you to the next stage. It's not too late. I know there are people who say endometriosis is a death sentence. I don't think it is.
No, it is
not a death sentence. And so we'll keep doing what we can. And thank you, Justus, for this platform. It is such an honor to be on this platform. I would say that. Daktari, asante sana. I think I'll join your class.
Karibu sana. Yes, thank you so much for this platform that we can be able to break down some of these problems in bites, which can be able to be understood by the common man. Having said that, I think I would encourage all parents who have teenagers, such that when your daughter tells you that I'm having, this extreme pain during the periods and it's cyclical, please don't dismiss it. The teachers as well, don't dismiss it, because it's just like one of those things, because it could be the beginning of, something which is drastic. So that is number one. Number two, even those ones who have this pain but have been keeping it to themselves, please contact a gynecologist. And endometriosis is not a death sentence.
It is not.
We have very many patients who have been treated and they are okay. And others, the treatment may take a little bit longer, but we'll get there.
Information overload. Quite a good way. I honestly have learned so much on this particular show. And I think it empowers me to even know what to do. And how to plug myself in such that this is not just a conversation for the women, but it's a conversation for all of us as a society. So I feel liberated, I feel empowered, I feel like I have a role to play, thanks to all this information. And I hope that this is the case even to you, as you have followed this conversation. And let's know what you think. Your feedback is very important. It will inform even our conversations in the near future. But most importantly, we want to empower you to be in a position where you can be able to take the next step. Hopefully, this makes it easier for you. Thank you so much for your time here on the Reproductive Health series on Shared Moments with Justus. It's always a pleasure having you join us every other week and on many other shows that we bring your way on Shared Moments with Justus. We thank you so much for having been here, being a loyal follower, and most importantly, we hope that every week you'll get something that you can be able to take home with you and improve yourself. Once again, my guest, Kireki Health Coach, Dr. Kireki Omanwa. Of course, we have shared and we continue to share their details. You can follow them on their personal social media handles, as well as give them a call if you have a need that you think they are the best fit people to address. Thank you so much for your time. See you again next time on the Reproductive Health series.